G'day and welcome back to the BroomeDocs podcast. It's another episode of the First 10 and EM Journal Club with Dr. Justin Morgenstern. G'day, mate. How are you?
Fantastic. Things are good on this end. I mean, really cool. It's minus 28 degrees or something like that outside, which I'm not sure that you've ever experienced over there in Perth, but I can't complain other than that. How about you?
We are good. Yeah. I was actually talking about weather. Yesterday was the semi-final of one of the cricket league here that we follow in Australia. And I took my boys along to the match, and it was 40 degrees while we were standing in the queue to get into the ground. There were a lot of large, sweaty men in the crowd, so it was very different to your life experience as it is at the moment. But it was beautiful, and we won, which is the best thing. So it was a great day.
That sounds great. Congratulations. That's always exciting. Good to get that you were able to go with the boys.
Yeah. Lots of fun. Now, we got some interesting feedback after our, 10 years of podcasting. I think that's the first feedback we ever got. And some people have required
surprisingly, our incredibly informal podcast is just maybe spun a little too informal. I don't know if we were better in the past or whether we've always been like this. And so the first person after 10 years finally stepped up and said, "You idiots, slow the hell down and tell us something valuable." Yeah.
So
even this is informal. We haven't even said what the feedback is yet. I can't take any feedback. I'm no good.
A little bit more structure, I think, is what people were asking for. Yeah. So we're going to try and give the people what they want. But just to sort of set the mood for how structured this podcast is, Justin and I have been doing this for nearly 10 years now. And every year when daylight savings comes around, because we're normally exactly 12 hours apart, so 12 p.m. is 12 a.m., but every year when daylight savings come, we always mess up the time. So Justin, I texted this morning saying, "Hey, you ready to record?" And he goes, "It's not for another 2 hours yet." And so that's here we are. I've dragged Justin away from whatever he was doing to jump in early. And we're still trying to decide which direction we were wrong in anyway.
Yeah, you would think in the era of modern electronics it would work, but I don't know. It says a lot about how much we must like each other to literally be the furthest points that you could possibly be on this planet Earth and still do a podcast together. It's a little bit ridiculous, but I enjoy our monthly chats, and we'll try to keep it going that way. The nice thing is you have to do it in the morning, and maybe you have a coffee next to you, but I get to get a little loose as the evening goes on and enjoy the evening. So.
Yeah, it's the opposite to what is our norm, which is me on the way down and you on the way up. So we'll see how we go. All right, we won't bore the people anymore with the meat that is inside the grinder of this machine, and we'll jump straight into the actual first paper. And this is a big paper for this month, so this is probably the one that's had the most discussion over the social media platforms in recent weeks. It's been covered by all the big podcasts and websites, and I know MCRIT and The Bottom Line and all that have covered it, and Josh Farkas has had some great thoughts about it as well. So this is the RSI trial, which is a big randomized controlled trial out of the United States. So 14 EDs and ICUs recruited, about 2,500 patients. I think they actually screened, I think it was nearly 4,000. So I think only about 2/3 of the patients they screened were actually included in this. And these were sick ED patients or ICU patients. They had about a more than 25% mortality. So these are the people where you're expecting to see a difference in interventions. Really important before you get too excited about this trial is that they did exclude a lot of people, and this is not a trial that included trauma patients. So don't put trauma patients in here, which is probably about half the people I intubate, to be honest. And they also excluded people if they needed urgent intubation, which I guess means they didn't have time to crack an envelope and properly randomize them. So the people that were true crash airways didn't get into this trial. So just keep that under your hat when you're thinking about this. And probably the one that's probably going to irk you the most, Justin, is your favorite exclusion is if the doctor thought that the patient needed to have one or the other intervention, definitely. Not sure what they were basing that on, but if they thought one was definitely needed, then they didn't get into the trial. And that always smudges the numbers a bit, because how are we going to know if we never actually include those people in the trial? So what did they do? So basically these are people that needed an intubation. They needed an induction medication, and they either got ketamine or Etomidate. The doctors were allowed to choose from 3 different doses of both of those agents, so they could go small, medium, or large, depending on how sick or how unstable the patient was. And then they followed them up to see who died, essentially. Is that pretty good for PICO?
Seems like a pretty reasonable question. I guess if you're really asking, going into Pico, the question is did they ask this question? And I think the underlying theory for a long time has been that etomidate might cause problems over the long run. Like if it was just who's dying more, you could look right in the moment in the intubation and it wouldn't be a problem. But there's been this theory behind the scenes that etomidate might do some adrenal suppression and something might be going on in the long run. And I think that's the primary reason for doing this trial. An all-cause mortality over 28 days is etomidate actually doing something bad in septic patients with the adrenal system, basically?
Yeah. I work in Australia. I've never physically touched a vial of etomidate in my life, so this paper is kind of interesting in a theoretical manner. Is it commonly used in Canada as an induction agent?
So it was popular in theory when I was trained, but very hard to find and I think very expensive at that time. And so I never used it in training. And so I just got used to not using it. So I think it just depends on the hospital and whether it was used a lot. It breaks down just like this trial does. There are some places that use it a ton and get really worked up about it. And there are other people who just don't care about this trial in general because they don't use etomidate at all. And I fall into have never really used it. So I wasn't all that worked up about the entire issue.
Yeah. And I guess one thing I couldn't get from the paper is that my understanding is etomidate is pretty much a pure sedative agent. Like it doesn't do anything for analgesia, whereas ketamine is obviously a very mixed drug. You get sedation and analgesia with it. So it's kind of a one syringe solution to the problem of an acute intubation. I couldn't see in the paper whether they added any analgesia in with the etomidate. Could you find that anywhere in the paper? Like did anyone get fentanyl or anything like that?
It's been a while since I read all the supplemental material, so I don't want to lie to our listeners, but I don't believe there were differences in the other drugs used aside from, as we'll talk about in a little bit, vasopressors. I'm glancing through right now, but I don't know. But when I was trained on it, the idea was, etomidate should be used exactly like propofol, which is, think about it. You might need some analgesia with it. It's just a propofol that was supposed to have a lot less effect on the hemodynamics of the patient. But that's a really good question, and that I don't think there were differences in the use of fentanyl, etc.
Yeah, I couldn't see it listed anywhere, so that would be an interesting thing to know whether the interventions were different because they did include analgesia with one and not the other. So yeah, cool. All right. So Justin, there's been a lot of ink and electrons bothered by this over the last couple of weeks, and some people are really hot on this. They really think that this is a practice changer. The actual outcome the primary outcome was mortality, which was essentially no difference. But if you look at the actual numbers, there was a small point estimate, about 1% benefit to using ketamine, which was not statistically significant, and that's probably just noise, but certainly didn't look like etomidate was better. But then the big problem with this paper is the secondary outcomes, and the big secondary outcome that everyone's been talking about is this sort of concept of cardiovascular collapse, which sounds bad, but is actually just a research term, which includes a lot of things, which includes a drop in blood pressure, reintroduction or a new dose of vasopressors. And that's obviously something that's very hard to say is that a true effect or not, particularly in an unblinded trial. So tell us your thoughts on that, mate. Should we all be switching? Is ketamine killing people due to cardiovascular collapse?
Yeah, so I think the hemodynamic stuff is going to be where everybody's conversation is. But before we get there, I do think there's one point. The longer this paper lingers with me, the bigger a problem it is. And I think this is a good example. I've probably said it a dozen, if not 100 times on this podcast, that modern power calculations are a bit of a joke. Like they're just made up on what you can accomplish rather than any actual science. And so this trial was powered for a 5.2% difference in mortality, which is insane. Like we knew it was going to be statistically negative before the trial ever enrolled a patient because you don't see 5.2% changes in mortality in trials. But initially I just wrote that as like a 2-line blurb, like who cares? This comes up in every single paper. But the longer I sit with this, people were really concerned. I wasn't one of them. I'm not sure that etomidate really increases mortality. I'm not sure that adrenal suppression really matters. But the whole point going into this trial is people thought etomidate was going to kill people. And etomidate was 1% worse than ketamine. This trial was not powered to show a small difference between the two groups. So I'm not sure that this actually moves the needle at all. If going into this trial, you thought, if you were one of the many people who thought etomidate was killing people, this data says that it's 1% worse. Like it still might be. And that's a huge problem for me. Running a giant trial. And these people did a great work. But that one detail that we often gloss over really, to me, sort of ruins it, because there was no way this trial was never going to be big enough to answer the question that was the whole point of the trial. Anyway, that wasn't actually the question you asked me, but the longer I think with it, the more this comes up. We do this because we have to get trials done pragmatically. But when you design a trial imperfectly for pragmatic reasons, you end up with these answers that don't actually answer the question you set out with.
Yep.
To deal with your hemodynamic question, I personally think that it's much ado about nothing. I don't know. You can go back to my main blog post. I think I ended up writing like 12 different paragraphs about this, trying to come at it from different angles. It's a composite outcome, and composite outcomes always are confusing. We spent a lot of time talking about that last time. But I think the easiest way to approach this is just to say mortality wasn't different. If anything, mortality is 1% worse with etomidate. So what hemodynamic collapse are you seeing if mortality is identical? Like it by definition is inconsequential. It doesn't matter. So I think that is enough. If somebody's talking to you about this paper and telling you should get rid of ketamine, you just say, why? Mortality is identical, so their blood pressure dropped for a second. But then more importantly, their blood pressure didn't drop. There was no difference in blood pressure, and there was no difference in cardiac arrest between the two groups. The only thing that changed was the number of patients who were started on vasopressors. But if their blood pressure didn't go down, I don't know why they were started on vasopressors. It's a little bit weird. And it's an open label trial. So people were making decisions based on the drugs that they were given. So at the end of the day, I don't know what to make about it, but I do know that it was by definition inconsequential. Nobody cares about cardiovascular collapse that has zero change in cardiac arrest and zero change in mortality. Like, I don't know what that means. That's not that's the cardiovascular collapse that has no impact on the patient is nothing. So I will continue to use ketamine. Ketamine's always been my drug. I see no reason to change it based on this data.
Yeah, I think I was reading Josh Farkas's take on this, and it was a really interesting table that he produced that looked at the use of vasopressors both before and after the intubation. And although there was like this 5% increase in use of vasopressors after intubation with ketamine, it was nearly half of the patient, 2 point something percent in the etomidate group actually got a dose of vasopressors before the intubation. So you just wonder whether this is just truly the unblinded bias going on here, whether people are going, oh, we're going to give etomidate, we might as give them a little squeeze of NORAD or a bit of aramine before we push the tube down, just because we're worried that might happen. So it's really messy data, and I completely agree. I don't think that we're going to be changing. I don't have etomidate, so it makes me breathe a sigh of relief and say, phew, I don't have to think I'm killing people with ketamine, because I think that it's one of those things that the grainy details are so small that we definitely can't draw any strong conclusions from this data, other than, as you say, that it pretty much leaves you exactly, if you use a Bayesian approach, leaves you exactly where we started, that if you thought etomidate was killing people a little bit before, that probably is where we're ending up with this, because the data would say that's about what you'd expect if etomidate was killing people a week later in the ICU. So all makes sense. Yep. Cool.
Yeah,
anything else you want to say about that?
Yeah, I think that's the key point. I made the point that etomidate might be increasing mortality by 1%, but if you were using etomidate, I would not critique. My personal pretest probability was that these agents are probably the same, and they're probably the same. I guess the only thing I would say, and I'm wondering your thoughts. We've talked about the process a little bit. Scott Weingart has said that he's actually going to change to etomidate, except that he won't, because he uses ketamine almost all the time because he does DSI, or delayed sequence intubation. And I actually do that a lot as well in these really sick patients, the agitated patients. But people think about it. DSI was for the agitated patients, but for the sick patients, titrating in your drug and keeping the patient breathing makes a lot of sense to me. And so I have been following Scott and doing that, little doses of ketamine. And the nice thing about that is you don't just have to go and slam 100 or 150 of ketamine. They might be dissociated at 20. They might be dissociated at 40. Yeah. So you cap out the amount of drug at exactly the dose the patient needs. You can't do that with propofol or etomidate because they'll become apneic. Whereas with ketamine, you can wait and then push the paralytic. So that's the one thing that I think is another argument towards ketamine in my mind.
Yeah, I think the doses here were way off with the ketamine. In the 1 milligram per kilogram was the lowest dose that you could give the patient, and I often give less than that, I think, in most of these really sick patients. And for exactly that reason that you just said, is that like when I'm doing an induction for a super septic patient in the ED. The nurse asked me, 5 minutes later, how much ketamine did you give? And I look down at the syringe and go, oh, I gave this much. I don't actually care what the number is. I'm giving little tiny boluses until I can see that they're ready, and then we push the rocuronium or whatever we're using till they're dissociated. So I think giving 1.5 to 2 milligrams for someone who's this sick, most of these were respiratory sepsis patients. It's way too much, I think. And I think if you're just patient and wait 30 seconds, 40 seconds, you'll end up using a much lower dose of drug. So I'm not a big fan of that set and forget sort of dosing of drugs in this situation. So I think that's very interesting. And I do agree. I think Weingart actually said that he's written a letter to the author about the dosing used in this paper as well. So it'll be interesting to see if anything comes of that. We'll keep an eye on the feedback and the erratums in the paper, and maybe the journal will publish that. That would be awesome. But yeah, I think that dosing is a little bit off. And like I say, the whole mixture of analgesia and everything, we don't really know from this paper. So interesting one. One other point I just noticed when I was reading this paper this morning, actually, is that this was done by that fantastic research group, which includes Brian Driver and Dr. Casey, who've done a lot of the amazing airway stuff over the years, the bougie first trials and all that sort of stuff. And their rate of bougie use in this paper was only about 1/3. So there you go. So for a bougie first, this is obviously not just the one ED. This is 14 EDs, but only about 1/3 of the patients got bougie first, which is interesting because this is a group that have advocated very strongly for bougie first techniques. So it is a pragmatic trial, and this is real life medicine. So interesting when that sort of stuff comes out in the wash.
Yeah, so I think this is a group that is doing some of the best research in North America. At least it's hard to get RCTs done in North America, but I think there's a reason. And I mean, we're probably harping to the wrong audience, but there's a reason that we harp on these minor research points to begin with. Because the problem is when you put in this amount of effort, but your trial sort of had a pretty fatal flaw from the beginning. And this was a big trial, so I don't know. Were you really going to get a 25,000 person trial, which it looks like is what you would need? I don't know. But if you know that, I think the problem is we need to move medicine towards the realm where we run big definitive trials rather than small trials that can't actually answer the question that it is. Although, from a Bayesian standpoint, I think that's fine. We're going to move the needle a tiny bit, which in this case, actually, we're not going to move the needle at all. And it still remains an open question on whether Etomidate kills people. And it just is what it is. We'll move in small incremental steps, I suppose. And questions will never be answered during our careers. So it's fine. I give them kudos, even though I think there's a reason we harp on the methodology things, because in the long run, you really want these methodology things to be addressed before the trial. It's not fun criticizing people who are doing great work after the trial. We want this done before. But anyway, that's a different rant. But we can get into that as I have a few more sips of my drink as we go. Should we move into I seem to make it an atrial fibrillation podcast. We're going to go full cardiology.
I was just going to invite any researchers out there that are designing a trial to send their methodology to Justin at first 10 a.m. and he'll sort it out for you before you.
Free consultation is good.
So this month's I think we've got 3 or 4 AF related papers in a row. So if you're interested in AF, you better tune in. If you're not interested in AF, just skip forward maybe half an hour or so and we'll. But AF is a fun condition to treat in the emergency department. So I think it's something that we do regularly. So it's worth spending a bit of time on. Go for it. Do you want to start with the first paper, the loop trial?
Yeah, so the first one is actually probably completely irrelevant to us, but I still think worth talking about. So this is the loop trial by Svendsen, 2021, back in the Lancet. And the core question of this trial is it worth screening for atrial fibrillation? Can we prevent strokes by just catching it asymptomatic atrial fibrillation? And so this is 6,000 elderly patients. You couldn't have atrial fibrillation, but you had to have risk factors for stroke. So high blood pressure, diabetes, a prior stroke. And they actually put in implantable loop recorders or randomized patients to either a loop recorder or standard care. And over the 5 years, it worked. Like they found a lot of atrial fibrillation. Something like 32% of atrial fibrillation of the loop recorder group was diagnosed with atrial fibrillation, as compared to only 12% of the control group. So at its face value, this intervention works. Screening for atrial fibrillation, they found 20% more atrial fibrillation, but the crux of their question was, is this actually going to help? And it did change management. About 20% more patients were put on anticoagulation, but stroke rates and arterial emboli rates were identical. It was basically 5% in both groups. Now, they didn't actually find a difference in major bleeding either, so you can't directly demonstrate harm, but clearly if you're starting a whole bunch of people who are asymptomatic on anticoagulation with no benefit, there's going to be harm. So that seems to be straightforward. So this is a classic, is one of our classic topics that comes up over and over again. Do more tests, you're going to get overdiagnosis. The screening tests are very hard to do, and that's what this is. So screening for atrial fibrillation doesn't seem to help. Now, obviously, we're not cardiologists. So I threw this in primarily, it was an older paper that I'd read before back in 2021. But I don't know about you. Tell me the Australian experience. But I see so many people who have basically this, but it's with a smartwatch. They come in with completely asymptomatic, but now they have atrial fibrillation. And I think this tells us how to treat them, but I'm interested in your opinion.
Yeah, no, I've definitely seen a huge increase in the use of smartwatch technology to diagnose or for people to present to triage saying my smartwatch tells me I need to be here because my heart rate's, 140 and it's in a funny rhythm. So, and there's lots of apps out there that you can get, which, your phone can detect this now as well. So you don't even need a smartwatch. So it's interesting. And this is definitely a phenomenon that we're seeing. And I really like this trial because I think it gives us good data that we can actually counsel patients with, to tell them what to do with this. So I think my one of my favorite lines that I find myself saying a lot over the last couple of years is you can't fix asymptomatic. And I think that's what this trial is pretty much telling us is that if you have silent AF you're not symptomatic from, there's been a few trials that have looked at this in the past, and we know that there's a lot of silent AF that happens out there in the older population, and we've always sort of suspected that that's where all the strokes come from, but we haven't had much sort of solid data, and this is a big, really well done trial. So the number of patients lost to follow up was 0. So that's pretty amazing for a trial of 6,000 patients that they didn't lose any to follow up, which is, I don't know what the Danes are doing, but I think they have a very socialized healthcare system over there. So that's unheard of. Almost seems too good to be true, but anyway, it is what it is. So this is pretty robust data, I think. And as you say, three times as many patients in the implantable loop group were diagnosed with some AF, and you only had to have AF for 6 minutes for it to count. So you could have AF for 5 minutes and 55 seconds and you wouldn't get counted as being an AF. And which is interesting because if the sort of physiological theory is that going in and out of AF is what throws the clots off, and that's what we all worry about when we cardiovert people. So is this really showing that, or is this? It's a tricky one because I think that's what we were always taught in medical school, is that when you cardiovert someone back out of AF, that's when you got to worry. But this data would tend to suggest that people are going in and out of AF all the time. And if you read the paper thoroughly, they actually do look at when patients had their strokes who had implantable loop recorders, and it was not related to when they were in AF as well. So they seem to have their strokes sometimes when they're in sinus rhythm. So that it's interesting. It sort of throws a bit of shade on that theory that it's that flipping back and forth, which is the risk for stroke. So interesting from that point of view. I think I do really like this, and I think that we can use this data to tell patients who present with asymptomatic AF that we can definitely hold off. We can do whatever it is that they need to do. I think looking at their other risk factors, and this is one that's really, I think, now in the realm of patient decision making. So patients who think that they are worried about having a stroke and do want to be put on anticoagulation, we can say, yep, sure, that's pretty much the gold standard in most of the first world. But patients that have contraindications or have other reasons why they don't want to be on it, it's also worthwhile saying that, well, maybe you could just ignore your AF. Justin, I think the only thing I can comment on this paper is a bit of a miss. I think it would have been a really useful trial. The patients were randomized 3-1 to get a recorder or not. It would have been good to have a third arm where they put a recorder in, measured it blindly, and then only acted on it, if the patient became symptomatic, if that makes sense. So if they had a group where they could just follow and see if they were getting AF, which was silent, and then followed that group as well with a recorder in, but not act upon it, that would have been an interesting third arm, because that's what I really want to know, is if we monitor people in and out of AF and don't act on it, do they do any differently? So that's the only way I would redesign this trial methodologically. But I think definitely gives good information to give patients who are trying to make that decision about anticoagulation or not.
Yeah, I mean, I think you're asking for like the whole point of an RCT is that you have to assume you have to assume the two groups are the same. And so if we found 20% more atrial fibrillation with the loop recorder, that means that the other group was having 20% more atrial fibrillation. We just didn't catch it. Like sure. The whole basis of understanding the trial has to be that. So sometimes randomization fails, but there's no reason to think that in this trial. So I'm not overly worried. I do think your point raises a whole series of thoughts to me. And I think maybe we have oversimplified atrial fibrillation. And I don't know what the bench researchers are doing here, but like clearly atrial fibrillation in and of itself isn't the problem. I just pulled up Chad's VAC, and if you go to the lowest risk group, your risk is 0.2% per year. So atrial fibrillation doesn't cause strokes. Like it doesn't cause clots. It only is when you add other stuff on. And I'm not sure how atrial fibrillation plus hypertension, which increases your risk a little bit, really go to make more left appendage clots. There must be more genetics to this, right? Why are some people getting large clots and breaking off MLA and some people aren't? We catch Chad's VASC, but that's a pretty crude tool that is currently being used. And I think they probably go a long way. I mean, screening almost never works, but we might be able to really hone in on our anticoagulation if we did a much better job of figuring out the genetics or whatever it is. It's called, because it clearly is not atrial fibrillation alone. It has to be atrial fibrillation plus something else, considering how low the risk is on a day-to-day basis, and considering how harmful anticoagulation is. That's something I would personally want to know if I was diagnosed with atrial fibrillation. It's not screening and finding more atrial fibrillation. Although if you knew you had these genetics, maybe then the loop implanter comes in works, or your smartwatch or whatever. So I think there's some major thing that we are missing here that isn't caught in terms of our decisions on who needs anticoagulation and who doesn't.
Yeah, absolutely. And I completely agree. And I think that's probably outside the scope of emergency medicine. Like we sit there and talk to patients. We're not the ones that are putting patients on long-term anticoagulation. Like we might start Clexane or whatever if we're worried. But this is a nuanced discussion that has to be sat down. And like you say, it would be great to know a bit more of the finesse of what actually is a risk factor for AF. Because, I more that I think about it, you often just see young people that have strokes for no good reason, and you think there must be something genetic going on with these patients. And then you see other people that have been in AF for 20 years and they've never had any problems. So, yeah, absolutely. I think it does make me relax a bit in terms of like what we actually do in the emergency department is cardiovert people, which I know that you and I both love to shock people whenever we possibly can. And it makes me much more relaxed about that because, like, we always worry that we're going to somehow create a stroke by cardioverting people, but I'm definitely much more relaxed about that. And I think most of my colleagues, and I think this paper makes me even more relaxed about it because what we know is
I think you and me are both naturally very relaxed. And what I picture here is some high-stressed colleagues are going to be even more stressed about this. Like I see the number of asymptomatic hypertension that I send home is very high. And I see other colleagues that find these minor symptoms on all these patients. So they're no longer asymptomatic. I can see the same thing. What exactly is the definition of symptomatic atrial fibrillation? If somebody comes in and they were briefly lightheaded for 30 seconds and they found to have atrial fibrillation, are they now symptomatic and they now don't, like this trial doesn't count? I can see people splitting hairs and really trying to broaden the definition of symptomatic versus narrowing it. And it's hard. Once you're in the atrial fibrillation, or once you're in the emergency department, you sort of, by definition, fall out of this screening program. And I guess you sort of have to take it easy, seriously. But again, if it's smartwatch, I don't know. How in-depth are you going for their symptoms at the time that they had it? I don't know that we know the answer to that. And it's going to be a little bit tricky because I think we can do a lot of harm by over-accepting these test results. And I don't know where you go.
It's an interesting one. Does being anxious about what your smartwatch tells you count as a symptom of atrial fibrillation? I don't think I'd be cardioverting people because they're anxious because their smartwatch is beeping at them. But I certainly am pretty liberal. So I cardioverted a chap the other day just because he was doing an exercise schedule to lose weight, which he was doing really well with, and he found he couldn't walk as fast as he could before because he was in and out of AF. He was in AF. So he couldn't exert himself. So that seemed like a reasonable thing to do, and he felt much better after he went back into sinus. So interesting. Yep. Yeah, but I don't. Yeah, smartwatch anxiety. I'm not counting as a symptom of AF at this stage. So let's move on to the next paper. So you're drinking, I think, is it bourbon? What are you drinking there? Whiskey?
Yeah, a little Irish whiskey this time around.
Irish whiskey, which my guess is that probably causes more AF than the coffee that I'm drinking. If you were to think about which poison is more likely to poison your heart into funny rhythms, certainly in the world I live in, alcohol is much more
stimulant. But alcohol should relax my heart. Caffeine gets me going. All my muscles are twitching. You don't think the caffeine's going to get you into atrial fibrillation?
Apparently not. So this is the DECAF randomized clinical trial. Essentially, this is the next step on from where we've just been chatting. This is patients that have actually had atrial fibrillation who have undergone cardioversion with their cardiologist. The lead author on this is Wong, and it's published in JAMA just about a month and a half ago, November 2025. And so essentially what they did is they did a randomized control trial of adult patients who had undergone cardioversion, and they were randomized to either stop drinking caffeine altogether, so abstinence from caffeine, or to drink 1 cup of coffee every day, so they basically continue on with what would be normal caffeine consumption. And the problem with this, there's a lot of problems with this trial, which I'm sure Justin, as a keen coffee drinker, will jump all over in a minute. But essentially, it showed that if you drank coffee, that it reduced your risk of recurrent AF, which sort of goes opposite to what we've all been taught and what we all ask patients when we see them in the ED. How much caffeine do you drink? So that's what it says on face value. But I think we can all agree that when you read the fine details of this paper, I don't think they're comparing 2 groups of patients who are almost identical. So, Justin, tell me, are you going to keep drinking coffee after you get your cardioversion in a year or two with all your whiskey consumption?
Yeah, I need somebody who's much better at biochemistry than I am. But I know that everyone knows how I feel about adenosine when used as a drug. And I know that caffeine acts by, I think, blocking adenosine. So therefore I love caffeine because it's blocking the adenosine. But I don't know that I know anything for that. So it makes sense. If you're blocking the adenosine, maybe your heart rate should go faster because it's the exact opposite. Yeah. I mean, I'm tempted to not critically appraise this much at all because it just says what I wanted it to say. I drink like 10 cups of coffee a day. My sleep may be not better off for it, but it's not going to affect my atrial fibrillation. So at least that gives me one excuse. There are some issues. I think it's really, really, really hard to design a trial like this or run a trial like this. It's just going to be selection bias. There is no coffee drinker in the world who you're going to go up to, no real coffee drinker, in my opinion, who you're going to say, I'm going to randomize you to take 0 coffee for the next, whatever it was 6 months. And they're going to say yes. Like that in and of itself is a very, very select group. And conversely, in this trial, which is really interesting, if you got randomized to coffee, you had to drink coffee. And so the low coffee drinkers demanding that they drink at least 1 cup a day is also narrowing in on who's going to say yes to this group. So despite these people being labeled as coffee drinkers when they get in, I think it was about 50% who were not drinking any coffee day to day when they were enrolled. And so changing from 0 coffee to 0 coffee, clearly not a very big change, and it's going to be hard to show a difference between the 2 groups if that's the change that you are making. And so that is probably the biggest critique. Obviously, you can't blind patients to whether they're drinking coffee or not, or at least it would be really sort of difficult. You have to go with caffeine tablets or something like that instead. And so if you were trying to use this data to prove that caffeine reduced the risk of atrial fibrillation, I think you would have to really dig in and realize that this data cannot show you that. But the fact that the atrial fibrillation risk was lower in the caffeine group take all those biases and throw them, I think you can be pretty comfortable with the idea that caffeine is not going to increase the risk. And they also link, there's a bunch of other papers that say that exact same thing. So I think that you can make a pretty strong statement that you don't have to worry your patients. Like if we're for us, that's the thing. We're going to cardiovert somebody, and what should we be telling our patient? And it makes sense. Like it makes intuitive sense that caffeinated beverages are something that you would want to avoid when you've just been like all keyed up. Everyone's had a little bit too much caffeine, and it does sort of feel like you're in atrial fibrillation, but you're not. You're just twitching. Alcohol is the one you counsel patients against. They can maintain their coffee, I think, is the end of the day answer here.
And are you ready for a double banger pun? I'm going to do a double banger pun. just to loop back to the last trial. They actually used smartwatch technology to diagnose atrial fibrillation in this trial. So we don't even know if the AF that they were experiencing was symptomatic AF. Like for all we know, they were just flipping in and out of AF for a few seconds. So, but that was less likely anyway in the caffeine group. I think, as you say, alcohol. In my world, I'd love to see a methamphetamine trial, because that's probably what I'd be counseling most of my patients about. If you stop using methamphetamines, because that will definitely put you back into AF. Well, not definite. I don't have the evidence to prove it, but I do see a lot of meth-related tachyarrhythmias. So probably one to avoid if you've just been cardioverted. But you've probably got bigger fish to fry if you're doing daily methamphetamine. Would be hard to get a trial up for that one.
We work with very different populations, but I will tell you, it's 3 for 3. So for whatever end it is, I have seen 3 patients who on either their 75th or 85th birthday just decided to try cocaine for the first time, and all 3 were in atrial fibrillation. And so that's 100%. I don't know. I'm pretty libertarian when it comes to drugs, but I do tell people over the age of 65 that this is not the time to start cocaine for the very first time. That's one of my very few drug counseling techniques.
We live in very, very different worlds, clearly. But cocaine is a very exotic and expensive drug of choice in my part of the world. So yeah, definitely not one that happens. So yeah, so I think we can close off the AF papers there. I think we've gotten through them all. We
got more.
Oh yeah, we do have one more. Sorry. I'm looking at the old version of your write-up, so that's cool.
Yeah. I snuck this one in.
Yeah. Cool. Should we go on to do you want to do the intro for the next one?
Why don't I introduce this one? Because this is all Canadian authors, led by pretty world-renowned Ian Steele as the first paper published in the PMID 2025.
Yep.
This is called the RAFF4 trial. And it's a trial asking the question, if you're using chemical cardioversion, everyone sort of knows procainamide sucks, but it's been the go-to for a long time, at least in Canada. And Canada does a lot of this. Apparently, there's a new drug that I had never heard of before this paper was published called Vernakalant. So the question is there a better option? And is Vernakalant better than procainamide in terms of conversion back to sinus rhythm? That's sort of the entire trial. It's an RCT out of 12 different Canadian emergency departments, taking people who were appropriate for cardioversion. You can check the write-up for the full list of criteria, but basically the guidelines said you were appropriate for cardioversion, and they randomized them to procainamide versus Vernakalant. It wasn't blinded. It's going to be my biggest quibble with this trial is I think you could have blinded this paper, but procainamide and Vernakalant go in at very different rates. So you would have had to have a double dummy setup where 2 different infusions were going to do that. And so they just went with the unblinded approach, and that's the big one. And their primary outcome was conversion to and maintenance of sinus rhythm. And I believe, I can't see it in front of me, but it was within 30 minutes of the ending your infusion. So an interesting, pretty clean trial aside from the lack of blinding, asking an important question, because procainamide, although it's our best option, does sort of suck. And I guess we can just give away the answers. The procainamide sucks. Vernakalant was better. 62% ended up in sinus rhythm as compared to 48% with the procainamide group. There was about a 10% difference between the 2 groups in the number of patients who needed electrical cardioversion, Vernakalant being lower. Fewer people needed that second step. And Vernakalant was about 20 minutes faster than procainamide. Adverse events were not statistically different, but again, they look better. It was 18% with Vernakalant and 25% with procainamide. So basically all the numbers across the board there favor Vernakalant. I guess the big question for you is, have you ever heard of this? Is it available in Australia? And do you even, so this is my big question. I don't know that this matters to me. Do you even use chemical cardioversion? Because you already told us you sort of like to shock people out.
Yeah, so first question is this available in Australia? No, it is not. This drug's been around for a while. Vernakalant or Vernakalant. I don't know. How do you pronounce it?
I said it right,
Justin.
Email Justin. I'm going to say it the other way from now on because I don't know which one I was saying, but whatever way I was saying was definitely correct.
So this drug has been put up by the manufacturer to the Australian TGA, which is our FDA equivalent. And I've read through there's 64-page PDF document about their application, and
we are such nerds.
The drug that we have in Australia, which sucks even worse than procainamide, is amiodarone. It's usually the first line for AF, which is I had a look back through the data, and it's actually worse in terms of cardioversion and side effects than both of these drugs. So, we need something better than amiodarone. But we don't have this available in Australia, and I can't understand why, because the trials, it seemed like some technicality in the way that the paper was presented, that they didn't have enough safety data. But, are you ever going to get safety data? A lot of other drugs get through these therapeutic advisory boards without this degree of safety data. And maybe this trial will change things a little bit, although this is interesting. It seems like a reasonable drug if you are going to go for chemical cardioversion. It seems as good as most of the other ones, or a little bit better than procainamide. The other drug that we often use in Australia is flecainide, with the caveat that you need to sort of know if the patient's got any underlying heart disease before you use it, which we usually don't in the emergency department. So that makes it a bit tricky to use. So I think this would be a good drug to have available if you do like that. And yeah, I completely agree. This trial seems pretty clean. It's not blinded, but having said that, they're sitting there on a monitor in the resus bay, and they're watching them for an hour or so. I think they're in the department for 9 hours at the end of the day, which is a long time. And they sort of know when they go back into sinus and if they stay in sinus rhythm. So I'm not too worried about the blinding in this context, because it's a pretty black and white sort of outcome that they're measuring. Interesting is that duration of stay in the emergency department, which they said was no different between the two groups, but they were both 9 hours. The last person I cardioverted was in the ED for about an hour, and I put him to sleep with propofol, shocked him, woke him up, and he walked out the door 25 minutes later. So I'm not sure that the big benefit of that would be a good trial. Would be we can look at whether Vernaculant's better than electricity, because I seriously doubt that it will be if your plan is to cardiovert someone. So interesting paper. Would be great to have it in Australia, so we've got another option. But once again, I'm going to opt for, if I think the patient meets the guideline criteria for acute cardioversion, then I'll always be offering them a dose of electricity as first line, because I think that's quicker and easier and probably has less side effects in general. Your thoughts?
Yeah, for me and for almost everybody that I work with, we needed a third group here. And it would have been a great trial with a third group, which was just electrical cardioversion.
Yep.
I should have pulled it out. In the back of my head, I know this group. I know Ottawa, where a lot of this atrial fibrillation cardioversion research comes out, has done some papers. I think it might have just been observational research, but papers looking at electrical versus chemical cardioversion. And I know the Ottawa group looked at that data and really likes chemical. And so there's this is in my province of Ontario, and sort of the eastern half of the province does a lot of chemical cardioversion, and the rest of us just go straight to electrical cardioversion. And I can't remember. I should have brought it up, because it would be an interesting point of conversation. But that third group would have been great here. I think there's a broader conversation, which is it's interesting in general. Some of the Americans who also don't have Vernakalant, so this whole conversation is not very useful to them, will look at us like we're crazy, because I know they mostly just do rate control. And honestly, at the end of the day, we know that rate control and rhythm control are basically identical. I think there's a lot of clinical judgment that can overlay there, and patient preference, and there's a reason I cardiovert the patients that I do. But when you keep that in mind, it is a good reminder that their primary outcome is actually not patient-centered at all, because they're looking for how many people converted to sinus, but in the long run, that has zero impact on the patient. And so the only patient-oriented outcomes here were how long they had to spend in the horrible emergency department, what were their side effects, what they went through, and the the outcomes were actually identical. So in terms of patient-oriented outcomes, they both spent 9 hours in the department. They both had the same admission to hospital rate. And so who cares how fast or how effective, like, you got back to a non-important outcome? Maybe a very, very reasonable argument, although I don't use procainamide at all myself. I don't know. I don't know at what point you should change your practice. Vernakalant is more expensive than procainamide, and a single unblinded trial in general, I would tell you, especially, I don't think they were heavily involved, but they did give the drug for free. So the drug companies are involved in the trial. I don't know when you change your practice. The flip side is 10% of patients having both procainamide and an electrocardioversion and those extra drugs, it's quite possible that Vernakalant was actually cheaper because you save the money on the ketamine or the propofol and the electrocardioversion and the pads and all that kind of stuff. So I think I think if I was a chemical cardioversion person, I would probably be trying Vernakalant at this point. I'm just not. I see no reason, especially with 9-hour stays. I can cardiovert somebody. I don't think any of these patients stay longer than 2 hours in my department, including their time waiting to see me. And so I can't see any reason to switch to chemical cardioversion. I guess there are a few people who are very scared of electricity for whatever reason, or have contraindications, perhaps with sedation. Maybe I'll pull it out if I'm not even sure if my hospital has it. I don't know.
So I think it is fascinating the look at the way that these therapeutic advisory boards, or the TGA in Australia, works, or the same in the US, the FDA, in that this drug didn't get up. And yet we've discussed them on this podcast, many drugs that are far less efficacious and have much bigger costs. So think about all the MABs that are used to reverse DOACs, for example, and things like that, which get approved, and yet a drug like this, which seems reasonably benign and has a widespread indication and seems to be a little bit better, doesn't get across the line. So it's a very strange world that we live in, and maybe they just need better lobbyists in Washington or wherever it is that they're getting done, because it seems like a drug that probably should be available on the shelf. There's no real strong reason I could see why that didn't get across the line. So interesting.
I assume money has something to do with it, but it sounds like it was really bad luck. I spent a lot of time reading about the US FDA, and the drug was already approved in Europe and Canada. So clearly multiple countries thought that there was good enough evidence for this, but the FDA asked for one more trial. And so that's where I think the money was involved. Somebody must have been on the other side. Amiodarone or procainamide or whatever. Like, why did they ask for one more trial when everybody else was happy? And that's where the unluckiness coming in. Somebody died very early in that trial, and that doesn't change much of anything. Like, it's a fluke event. But as soon as somebody died, they shut the trial down, and because they couldn't get the trial that they wanted to for safety, I assume that's the same thing. The Australia just followed the US's role, and so basically, it sounds like this is dead for both countries, even though it's pretty clearly better based on what we have than the option that's currently available.
Oh, well, someone just needs to get a black box label on procainamide, and Vernakalant will be back on the market. That's usually how these things go. So, yep. Cool. All right, we'll get off AF or convert to something different. High five. No. This is probably...
We should record more often when you're on coffee, because your pun or segue game is high when you're on coffee. But
I think
if anyone's appreciated it.
The dad joke puns are going off this month because I've just spent 6 uninterrupted weeks with my teenage boys. So, that's the only way I can engage with them is by making stupid puns. So that's where we're at the moment. I've been practicing. This is a really cool paper, so I'll just do a quick intro. It's a bit of a theme on this podcast. We have one of these papers most months, but this is one of those editorials. It's in the Australian Journal of Emergency Medicine's journal, which is the EMJ. It's published in December, so Christmas last year, just a month or so ago. The lead author is Daniel Stewart, who comes from a town called Dubbo. You know where Dubbo is, Justin? Sort of big.
I mean, it's in Australia. But I actually do think that.
If you drive from Sydney inland, basically, you drive inland from Sydney, sort of over the hills, and you head towards Dubbo.
Yeah. So I don't know if I ever made the drive. Like, I worked in Broken Hill, which is like very far inland from Sydney.
You might have driven through Dubbo on the way. Who knows? So, which is sort of a large regional town. So I'm so happy that there's someone in a place like Dubbo writing papers, because it's sort of, I can sort of imagine Dr. Stewart, and I've emailed him and let him know that we're talking about this, but I can sort of imagine him sitting there getting bored to death in an emergency department thinking, how can we fix this system in the big hospitals? And he's written this amazing paper, which is called The Emotional Analgesia and the Decline of Rational Decision-Making in the Emergency Department. And I think we've talked about this topic multiple times, so I'll just quickly explain what it is. Basically, he's looking at, and he quotes one of my favorite papers of all time, which is by Piker and Cassier, is it? Which I think I quoted at my talk in Dublin, where I first met you, Justin, 10 years ago. There you go. Which is the sort of threshold decision-making for diagnostic testing in the emergency department. And so he's sort of saying that, yes, we should be using threshold decision-making, but what in reality happens in emergency departments nowadays is that people get front-loaded with a whole heap of investigations, including a lot of blood work, CRPs, full blood pictures, D-dimers, all these sorts of low specificity testing, which happens at the front of the house. And essentially this just creates a heap of noise, so a lot of static to our background. And he describes this as emotional analgesia because we lack certainty, and it pops up on the computer screen from the lab and makes us feel good about. It's kind of like a pacifier or a dummy for diagnostic decision making. You feel soothed because you've got objective data that you can go off, but in reality, it's not actually helping us at all and making us essentially. The really interesting thing here is he phrases this in terms of training. He says that whole generations of doctors are getting trained to essentially be reliant on the emotional analgesia, or the pacifier that is these low quality tests that we do at the front of house, and they're not learning to make actual rational decision making as a result. It's a two-page editorial, well worth the read. Something that we've been advocating for many years on this podcast, and yeah, I really like the paper. It's a nice little metaphor to sort of think about it as a sort of pacifier and making us all feel better, and that's why we do this. It's a sort of a good way to beat people over the head if you want to have a read, or leave it on the coffee table in your tea room next shift. Yeah. Justin, are we preaching to the choir?
One of my favorite papers of the year by far, Ruben Strayer sent it to the two of us and actually thought that maybe I had ghostwritten this on taken out a pen name. He thought it was me who was writing it, which I'll actually put it out there. I don't know if Daniel Smith. No, I have Daniel Stewart. Dr. Stewart ever. Why did I write Smith multiple times in my paragraph? Sorry, Dr. Stewart. But if you ever listen to it, you are welcome. Anytime. If this is the kind of stuff you write, you can write for First 10 AM anytime. I hope publish without an edit. You can just put up open invitation, because this was brilliant. Relief-seeking decision making. CRP is not information; it is emotional analgesia. I think that is all fantastic, and I think he's right. He centered this around CRP, and his quote at the end is: "The central concern is not the unnecessary test itself, but the thinking that it displaces." And I think that's a lot of what we do, right? It's sort of the whole point of doing this critical appraisal podcast. I don't actually care about any one paper or any one topic all that much. People have reached out to me about thrombolytics for stroke all the time, and I don't care. I care about the critical thinking underpinning the science, and it's the same thing here, right? Do I really care if you sent a D-dimer for aortic dissection or a CRP for appendicitis or whatever? Not really, but it's just a sign that you don't really understand how these tests work. And too often, emergency departments have routine tests, but we say over and over again that you should know whether a test is going to change your practice or not before you order it. You should know how you're going to practice on it. So how can you possibly have routine tests when you need to have thought through the results of every test before you sent it? So yeah, no, I think I agree entirely. And I think probably all of us can reflect on this a little bit, because this is systems and everyone's a little bit different. And as much as you and I can make fun of this, in the 8th hour of a very hard shift, do I also get stressed by uncertainty in patients? Do I also try to let the CT scanner solve uncertainty for me? Yeah, so sometimes you want to push off a decision, and so you order the CT or you order the blood work so that you don't have to make the decision. You still have to make it. You just make it 2 hours later. But that is normally my cue to go and get a sandwich and get a coffee or whatever. Normally there's something else wrong, but I think it's something to monitor. It's that metacognition and recognize that as soon as you start allowing a test to make a decision for you, you're probably not in the best frame of mind to practice emergency medicine, and maybe it's time for a snack.
Very good. I think I will push back on a little bit, because I think the big problem with a lot of these testing is that they're doing a lot of those front-loaded tests that we mentioned, sort of dimers and C. They're very non-specific tests. Whereas I think if we did more specific testing, and in the emergency department, that's pretty much imaging. Is most of our more specific testing is imaging. Which is also expensive and time consuming, then that is something that would actually be more useful and would actually be a lot better for decision making. And I just got to put a little story here in that my job when I work in my big shiny emergency department is I work as an ultrasonographer in the ED, and I look at a 20-year-old bloke comes into the emergency department with right lower quadrant pain that started periumbilical and migrated to his right iliac fossa. And I know that this is going to be appendicitis, with about a 50% certainty before I even call him out of the waiting room. And then if I put the probe on and I see a blind ending sac that's inflamed and with a bit of free fluid around it, I know that this is appendicitis, and I can say, right, this is what you got. But it's without doubt, this patient will not get admitted until they've had a full blood workup as well, including a CRP and a white cell count. And that's where the problem is that we've trained a whole generation of junior doctors and registrars, and our surgical trainees, for example, just cannot accept patients without blood work. And it just does my head in when you're doing all the work for them. You've made all the decisions on their behalf, and then they want to go back to this point of, we need to get the blood work. And I sort of have never really understood what's driving that. I don't think it's their superiors, their boss, their consultant surgeons that are asking them to do this, because I'm sure that if I called the old surgeon and said, look, I've seen an obvious appendicitis on ultrasound, they'd just take them to theatre. They'd be happy with that. But I think this is what's happening. Is it's this emotional analgesia, and that's why I love this paper, because it sort of explains why people are so reliant on these tests. Because I think it does make you feel better when you've got this objective marker, which is other than and it pops up on a computer screen and it tells you that there's something going on. Unfortunately, obviously, non-specific data can't actually help you most of the time, so it just muddies the waters often.
Yeah, I mean, I spend a lot of time. I don't want to be a other specialty basher, and I think everybody who listens knows I spend a lot of time bashing out my emergency medicine colleagues for the tests that we order. So it's not a thing. But I do wonder how diagnosis is taught. I had a patient not that long ago who had heart rate of 140, blood pressure of 80 on 40, severe generalized peritonitis, abdominal pain, lactate of 6, and CT proven perforation. And so I call the surgeon, being like, come get it. Yeah. And the surgeon on the other end of the phone looks at the computer screen and says, but the white count is 7, so I think this might not be surgical. Maybe get medicine involved. Excuse me, back up. But for some reason, that white count or that CRP has replaced it in some places. Luckily, not Canada. It's taught as the be all and end all, which is and obviously that's an extreme case, but it is. That's why I love this paper so much. It becomes this thing that just replaces thinking for some reason. It's a switch, and you're trained to try to reject patients or whatever it is to monitor your workload, and thinking turns off, and that's why I love the paper so much. I do think there's a role. It's an interesting conversation. I think when we talk about these front-loading tests, I think we also turn off our brains a little bit, because there are patients that are almost 100% algorithmic, right? If you come in and you tell me I'm pregnant, I have some low pain, and I'm bleeding a little bit, you're going to get an ultrasound. So if the nurse would put in all those ultrasounds at the front, that would be great, but that's never put in. Instead, I get an elderly patient who's a little bit weak and dizzy, and for some reason, a bunch of labs were sent, and I'm like, I don't even know what I want on this patient yet. We have whatever the protocols are that set these things up, and every hospital I've ever worked at is just incorrect, because there are definitely patients that 100% of the doctors are going to order the exact same test every single time, even if it's a little overdiagnosed, even if it's a little bit much. It doesn't matter. So those are the ones that should be front loaded. But the complex patients, for some reason, those are the ones that everybody wants to get a bunch of stuff going on. And I don't know. I think you need doctor first. But
Yeah, absolutely.
Like a rare opinion, unfortunately.
Yep. Expensive and time-consuming, unfortunately. Cool. All right. Shall we move on to our next paper? And the next paper was sent to us a little while back by an amazing young researcher by the name of Ben. So this is from the TURN network, which is the Trainee Emergency Research Network. I think we covered one of their papers a while back. Can't remember exactly what the topic was now, but we did cover something. So this is out of the NHS, and the NHS is this huge monstrosity of bureaucracy, but they have this amazing group of trainee researchers that are emergency trainees in their departments that do this amazing big scale research, which can give you some really useful data. And this is the TURN network that we're talking about. And this paper is entitled Understanding Corridor and Escalation Area Care in 165 UK Emergency Departments, a multi-centre cross-sectional snapshot trial. This is in Emergency Medicine Journal, once again, December 2025. And basically what they've done here is this is an observational data set where they've chosen 5 periods, so snapshots of over a course of about 10 days. So I think it was like a Tuesday, a Thursday, a Saturday, a Monday, a Wednesday, or something like that over a 10-day period, where they just took a snapshot of what was going on in each of these 160-odd emergency departments and where were the patients being cared for. And they were specifically looking at who was being cared for, receiving care in what they very politely, in a very English way, call an escalation area, which I think an escalation area is a very polite way of saying they were in the corridor or on an ambulance ramp somewhere, which doesn't sound like escalation in any definition that I know of, but sounds like
escalation.
Yeah,
degradation.
Degradation. Yes, it should be called the degradation areas. So, and what they found was that 18% or nearly 1 in 5 patients were receiving care in an area that wasn't really designated as a clinical care area. So that's pretty. That tracks with pretty much everything I've heard out of recent years, and that probably what's happening in my department at the moment as well. And the other interesting stat that came out of this, which was probably the headline, was about 10 to, sometimes it was more, especially I think it was on the Saturday morning, about 10% of the departments didn't have any resus bays available in their department, which is a big problem. So if someone comes in cardiac arrest or in rapid atrial fibrillation and you want to cardiovert them, you've got nowhere to do it because there's no resus bay available. And these patients these are the ones that are going to suffer, because it's, to some extent, the patients that are waiting for a bed on the med ward, they're getting the care that they need. It's just not very pleasant. It's not very private, but they're not going to die. Well, we have seen that French study that showed that, yes, they are actually more likely to die if they hang out in the emergency department. But it's these patients that are coming in that can't get the care they need because there's no access to acute beds. They're the ones that are really going to suffer. And we've been saying this for years, that essentially the problem is not how many ambulances come in the front door, it's how many patients are sitting in the emergency department waiting to go somewhere else. So we need to fix the back door before we can sort out emergency departments all over the world. Very useful paper, and if you're in a department that's struggling or you're needing to negotiate with your local executive or your local minister for health, this is a great paper to sort of point out how bad things are across the world, and it would be very easy to replicate this using essentially data. Well, not easy because this is a huge data undertaking, but it would be a very good thing to replicate in your system just to prove the point if you're trying to make this point to your executive crew. Justin, thoughts?
Yeah, I mean, I debated a little bit about whether we include this. I love this trainee research network. That is, I love trainees doing research, and they do good research. This is more valuable for the UK because the government has said we don't want to be doing this, and now they're showing them you have done it. So it's a very, very good political piece of research. And as you say, I think people should be trying to reproduce it, but it doesn't have the piece that we really want. We covered the French data, but we've covered there's lots of data that says and outcomes are worse for these patients, or outcomes are worse in this situation. And it's pretty obvious that they were. And you don't need to have that because, patients are human beings. And on your sickest day, when you're in with cancer and vomiting, you shouldn't be cared for in a hallway where everybody can see you. So there's a humanity side of medicine that says it doesn't matter if outcomes are worse. But I think to sell it and to make the problems worse, you need the outcomes data. And this is pretty specific to the UK. So those were my arguments. Like maybe it doesn't rise to the level of an Australian and a Canadian talk about it on a podcast. But I settled on including it because I think everybody in the world that I've talked to. Like, I don't think anybody doesn't have some kind of issue with this, and there's spectrums of how far it goes. And I think a natural instinct about a lot of people is to blame local people. And in Canada in particular, that the instinct is therefore to blow up our single payer socialized healthcare model and to move something more American, private. Pumping private money into this is going to save it. You're like, has anybody actually been into an American hospital? Because it ain't going to save it. Like, I think it's nice to have a reminder that this is still a worldwide problem, and it's a worldwide problem because nobody wants to fund healthcare. Healthcare is not a money-making business. It's a service, and it's going to cost money. So that's step number one. No government wants to fund it, and no private insurance company wants to fund it either. This is part of why private is worse, because they're going to reject you more often than the government is for your payment. But I think it's bigger than that in emergency medicine, and I think there's two big things that probably need to be said in every emergency department around the world. Number one, our staffing models are just incorrect. The people who want to staff hospitals for the average for the year. But we know that's inappropriate. We have to be like hospitals. We have to be at 80% capacity most of the year because you're going to have that surge. For hotels, it's this Christmas surge, but for us, we know it's the flu season over and over again when people start lying in hallways. And until you get that, yes, you have to overspend. It means that you're going to be overstaffed for a bunch of the years, but I guarantee you we can find work for those people on other days. We can do more drug counseling. We can do more other things. Like, it's not a big deal, but you have to staff for the peaks, not the average. That's number one. Number two, for some reason, the entire waiting room problem of every hospital, almost every, there's a few who have solved this, but basically every hospital, for some reason, has been dumped entirely on the emergency department. And I don't know why. I have 55 admitted medical patients in my emergency room right now. And so we're trying to create extra waiting space in the emergency department. But why are those patients waiting in the emergency department? They could have the same recliners or stretchers on the floor on the medicine ward. They could go somewhere else. And I know other countries do different kinds of things, but waiting rooms can't only be in the emergency department. That doesn't make any sense. If you are a medicine patient now waiting, you need to wait in medicine land. If you are a surgery patient now waiting, you need to wait in surgery land. The waiting room for the emergency department needs to be for patients who haven't been seen in the emergency yet. And until you solve that, this is a disaster. But of course, those floors can't take patients endlessly, and I understand that. It's not dumping on the medicine floor, and the way to solve that is you have to fund. You have to solve the first problem first. And so that's why I thought it was worth including, even though this data, it won't specifically be all that useful to people outside of the United Kingdom.
Yeah, and just emailing with Ben, it sounds like they are actually trying to produce that next set of data that, once again, like the French trials we've covered in the past, will show the harms of this phenomenon in their system. So that'll be a really interesting paper to read as well. But yeah, completely agree. This is not an emergency medicine problem. This is a hospital problem, and universally seems to be the problem everywhere in the world. And if someone can solve that problem in a way that doesn't cost more money, then they'll be doing very well and will probably win a Nobel Peace Prize. They're just giving them away nowadays, aren't they? So don't worry about that.
Not touching that one. I still may want a visa for travel at some point. I don't know.
Cool. All right. Thanks. We'll look forward to reading the next paper. But if you're in the UK and you want to see what's happening, then have a look at that. And big shout out to all those trainees that are doing that research, because that is high quality research done in a really sophisticated and coordinated manner, which it doesn't happen in many parts of the world. So well done, crew. Amazing. Next paper we're going to move on to is about expired medications. We've covered this sort of stuff a few times before, but it's the use of expired resuscitation medications for life-threatening first aid conditions. This is a systematic search and narrative review published in a Resuscitation Plus September last year. So Justin, it seems to be something you're very keen on, because we've discussed this a few times, but this is essentially looking at medications that are out of date, so they've passed their bottle expiry date. Do they still work, and can you use them? And this was a group, I think it was a group of pharmacists actually, was it, that published this paper from memory?
I'm actually only at this exact moment realizing that I was semi-duped. So this is the third paper in a row that was actually emailed to us. And a really great mate and very smart dude named Aaron Orkin sent this to me. And I thought he was just sending it because it was an interesting paper and he knew I'd be interested. But I'm now realizing he's the senior author. I only looked at the first author. So he should get his paper out there. So he's an emergency doctor, but all around fantastic dude. And you're right, we have covered this in the past a little bit, but I've always argued that expiry dates are mostly a scam. But most of the data that I've covered, or that I remember at least, was like, we found this military cache of epinephrine and it's all good. But most of it was stored in like a cool, like they were well stored. Whereas this is real world data from like first aid kits that are just being tossed around. And I think that is an important difference, right? If your epinephrine is in your car and it's going to 40 degrees and then down to -10 and back and forth, that you theoretically, at least that could make a bit of a difference. So the specific question that they were looking at was more, they really were just looking at first aid drugs. They wanted to look at 4 important first aid drugs that might come up if you were grabbing a first aid kit or if you were on an airplane. So that's aspirin, epinephrine, albuterol, and naloxone. And they used this systematic review to ask what percentage of the drug is still there after the set expiry date, and were there any important impurities or byproducts? And the answer was basically no. Like it all looks fine. Albuterol, like 98% of its drug was still there at 30 years with less than 0.5% impurities. So albuterol you can just not worry about. Aspirin was like 97% at a year and 90% by 40 years. So like it's there, no harmful products. Naloxone was 100% present at 19 months. High levels is the only quote, up to 27 years. Epinephrine is the worst. And we covered it before, and this is why I thought it was interesting. But it was like 90 to 95% after 35 years. This was only 55 to 75% after 10 years. And that's the point of regular storage. So lower doses sound like they might be important. Like I think if you had a layperson listening to that, even 90% of aspirin at 30 years sounds like I'm only getting 90%. I don't want that. I want 100%. But obviously every doctor, at least if you pause and think about it, realizes that all the drug doses we use are entirely made up. Like 81 milligrams of aspirin, 100 and like nobody knows how much you're supposed to take of any of these kind of things. And especially because 3 of the 4 of these are entirely symptomatic. Like if the first dose of epinephrine doesn't work, and it was only 55%, you give another one. So like the whole question of do you use expired drugs is the answer is obviously yes. The only concern I would have is if there were harmful byproducts in these, and basically in this review they didn't find any, and so. It's a nice little addition if you're on a very old airplane or you pull up an old first aid kit and you're just wondering, should I use this or not? The answer is yes. The larger issue, if you wanted to rant about it, is the same as like food expiry dates. The amount of food worldwide that we throw out because, the Western world wants the food to be perfect. Like there's the difference between best before and expiry, right? The food isn't bad. It's just maybe a little bit stale, but you could still use it. But as soon as it passes that date, you're not allowed to use it, even if you're like moving it from my house into a shelter or whatever. And so I think the same thing happens with drugs. I know the same thing happens with drugs. So I think systematically it would be good if we tried to expand these dates so we're not throwing out drugs all the time. Like that is stupid. Obviously, it requires a lot of research to prove that it's safe. And why would the drug company want to do research that loses them money? And so it's something that somebody has to tackle, but it's going to have to come from a government standpoint. But for us as individuals, the answer, it seems pretty clear every time everybody looks at this, just use the drugs.
Yeah. I think in my part of the world, this is really interesting because we have the Royal Flying Doctor Service, which basically the way they work is they have all these planes that go out and do retrievals, but they also provide these emergency medicine kits, which they live in like remote cattle stations and nursing posts, which are, you've traveled around Australia, like they're literally in the middle of nowhere, and they have to replace them every so often so that they know that all the drugs that are in their sort of emergency medicine caches are in date. And if you look at this data, they could probably decrease their expenditure on replacing these boxes significantly by just because most of these drugs never get used because they just sit in a box in the middle of the desert for 10 years and no one ever comes across them. So it'd be interesting to look at that data and see if they can change because it's a useful service, but I imagine the cost would be about 1% if they didn't bother replacing them every 10 years, because they have to replace them, keep them in date, obviously. So interesting. Next time I take a call from someone on the side of the road in the middle of the desert, I'll just say, yep, just take 2 of those baby aspirin. That's fine, because that's the way to go. And quite confidently say you're not going to do yourself any harm. So I think in that scenario, the risk benefit is so far tilted towards just accepting that these drugs are still working, because the 1 in 1,000 times that someone's having a heart attack in the middle of the desert, it's worthwhile. So yeah, go for it. Yeah. Cool. All right. While we're on the topic of expiration, should we move on to diagnosing dying? Sorry. I'm going to roll this month, Justin.
you're real bad, but yeah. So this is another friend. Peter Brindley is famous of SMAC terms, and at basically every conference and podcasting of his own, likely way bigger than ours. I don't know Matt Morgan, who's the second author, but somewhere in Europe. I can't remember. I don't have it written down. France, I think. Okay. Maybe UK. So another two ICU docs talking to us about dying, diagnosing dying. Is it time for doctors to write dying certificates? Is the title of the paper in the BMJ from 2024. It's another essay, so there isn't really a PICO study, and it's really hard to summarize these kind of essays in any kind of way that captures the essence of what they are. Like, this is just such a quotable paper, and it's only 2 pages. So if you're interested at all in what we have to say, I just say don't listen to me and Casey talk about it. Go and read it for yourself. But I think they make some pretty good points and have some pretty quotable quotes in here. The idea that in order to save, I can't find the quote in front of me, but in order to save a 20-minute conversation, we're willing to put people for 3 weeks into the ICU is one of the general good concepts on here. We'll default to 2 minutes on the machine. Basically, the idea that they're lamenting is doctors are sucks. We're unwilling to be definitive. We're unwilling to communicate clearly because it's hard. Prognosis at the end of life, mate. Even when we're
hey, we just had a big pause there. Sorry. Yeah.
Okay. I think it's recording. Okay. I think if you look at the we'll be fine. Yeah. Okay. And if not, whatever. I think the listeners will be good. Yeah. So basically, I think their concern is that we're sucks and we're unwilling to communicate clearly at the end of life. And they acknowledge that it's hard, but we've gone from an era 100 years ago where everybody died at home and they died with their family and their pets and their loved ones, to an era where if you have any chance of dying, you're whisked away to a sterile room full of machines. And often there's visiting hours, and you definitely can't get your pet in with you, and you definitely can't get any of your loved ones in with you. And so that's the idea of the dying certificate is some kind of better way of communicating that this patient is likely dying, even if we're not entirely right. I don't think anyone's adopting the certificate, but I do like the language that they recommend. Just this patient is sick enough to die. Not guarded prognosis, not anything else like that. They are sick enough to die. That is a pretty clear way to say, I don't really know, but expect it. And in that case, you can prepare both the patient and their family that dying is a real possibility. And let's have a conversation about how you would want that to happen if it does happen. Do you really want to be in this environment? Do you really want, to be on a breathing machine as compared to the ability to talk to your patient, take a few sips of whiskey in your last minute, whatever it is that you might want to do. So yeah, I again, you can't capture somebody's essay like this, blathering on without reading it out. But this is highly readable, and I think anybody working in critical care should.
Absolutely. This has been going on for so long now, and I think ED palliative care is sort of something that has taken off, I think, mainly in the US, where, well, it's the only route to care for a lot of patients, unfortunately. So I think that's probably why ED palliative care has taken off. But certainly in one of my hospitals I work at, we have a lot of very old people who are in that last phase of their life. And I think reframing that conversation with a positive diagnosis of your family member, or you are at the point where you're sick enough to die, how would you like to proceed, is much better than let's do you want us to do everything, which is the usual question that gets asked, which the answer is invariably yes. And so we do need to reframe this. And the thing that comes to mind when I sort of think about this problem in the modern Western world is that if you think about significant life events, birth, death, marriage, like how much planning goes into someone's wedding is ridiculous compared to how much planning goes into someone's dying. And so if you think of yourself as the ED doctor, as the dying coordinator or the wedding planner, and you get to give the person the options, like who do you want to be there, where do you want to be, how do you want it to go down, which is what you get to do for your wedding. Having said that, you only get to die once. You can get married a bunch of times if you want to. So that's the way I like to frame these conversations, is more about what the patient's preferences are. You tell me how you would like this process to go, and then we'll try and make that happen. And if that's you do it at home, then we can try and get palliative care to get the person back to their home to do this. But it often happens in the middle of the night in the emergency department, and it's really difficult to have that conversation. And so I think we as emergency doctors are not the right people to be doing this. This is really something that primary care or the patient's long-term neurologist or cardiologist or oncologist should be having these discussions with people, or even just putting the thought in their mind, how would you like this to go down? And then when the moment arrives, when you are sick enough to die, how would you like us to enact that? And we have enduring powers of attorneys and all sorts of things in Australia, and I'm sure around the world, like I'm not sure what they're called in Canada, but sort of legal mechanisms to do this. But it's still vanishingly rare that people actually have an active plan as to how they want to be treated in their dying hours. And so it puts a lot of stress on families in the acute moments. So it's definitely something where a conversation has to happen, days, weeks, months in advance rather than in the moment, which is where we often get landed, unfortunately, still in the modern era. I'd say of all the patients, for example, in our hospital that are on dialysis, if you think about people that are on dialysis, like I just don't see how you could have been on dialysis for 5-10 years with no goal of ever getting a transplant. And not have had this discussion, because it's going to come up eventually. And those patients in particular, they have a lot of options available to them. So worthwhile reading this paper. But as I say, I don't think it's emergency doctors that get to make these decisions. It's really ICU docs that are going to be doing the most of the heavy lifting, but it should really be the long-term chronic care doctors that are having these conversations rather than us at the end of the day.
Yeah, I might push back. To me, this does feel, I think it's easy to push off, and maybe it depends a little bit. You guys got your 4-hour rule. You're getting people out of the emergency department pretty quick. But it's not something that is at all fun, but sometimes medicine is a serious job. And sometimes in the first 30 minutes, you just have no bloody clue what's going on with the patient. And it's fair to say, I don't know. But most of the time, you can at least put your foot down and make some stronger statements. And I think too many of us, myself included, resort to wishy-washy language. We hide behind it. We don't want to be, we almost feel like we're going to be blamed for the death, even though the patient came in dying. And so we may not make the final decision, but how we phrase things really sets things up for the ICU. And it's not unusual for me to make somebody fully palliative and guide them through that process in 3 hours in the emergency department if they come in incredibly sick, because it's pretty obvious that it's the right thing to do. Now, it's easier if they've had even a modicum of conversation. It's easier if the family's all on the same page. Like, I'm not saying that you should take the systems issues and put them all entirely on your shoulders, but you won't know if everybody's on the same page if you don't breach the question. And I think that's on us. And at least I have not used it, and I'm going to try to remember it. But this patient, the patient is sick enough. I'm not going to say the patient, but they are sick enough to die. Starting there and even just pausing and seeing the response, I bet you that gets you everything that you need to know. If the family just says, "Yeah, we know that, we've been expecting that for a while," okay, we're all on the same page. Now I can proceed very quickly with what you were expecting out of me, which is hopefully comfort at that point. So honestly, we talk too much. I bet you if you just say, they are sick enough that I expect that they might die in the next 12 hours. And if you just shut up and said nothing for a minute, the family probably feels it. They might just say they absolutely not. This might be shocked. And then that tells you you're going to do everything, get them to the ICU, and you can have a talk with a social worker tomorrow. But that pause after being very blunt with your language, I think is something that we all need.
That's a very simple takeaway from that paper. So I think being very uncluttered in your thinking in that moment is really useful. Yeah. Cool. We'll move on to the last paper, which is, of course, the most important paper of the month. I'm sorry. I'm trying to think of a...
When I first read it, I thought I had to include this paper. Reading it back 2 or 3 times, I don't really know why. I guess let me introduce
I'm trying to think up a good segue, but I'm coming up with nothing. Go for it.
This is don't ask me how I got to this paper. This paper is entitled Tracking Domestication Signals Across Populations of North American Raccoons, the Procyon lotor, if you needed to know, via citizen science-driven image repositories. I think this would be the Frontiers of Zoology,
sure.
October 2025. So it was like fresh off the press. If you wanted a PICO, there's a broad theory that it sounds like phrenology to me, but there's something called domestication syndrome. That basically our domestic pets all look very similar morphologically because they're supposed to not scare us. And part of that is having shorter snouts and big floppy ears. Picture cute cats and cute dogs as compared to wild animals like a wolf with a big snout and sharp ears that are naturally scary. And so this whole paper got a bunch of data, people taking images on an online repository that I don't have in front of me. But they gathered all this data of raccoons in North America. And basically, they measured these facial characteristics and they had the geotag of where the picture was taken. So they knew how far from a city center they were. And so the idea is the more humans there are, the more likely you might be adapting to the human environment, trying to make yourself cuter so the humans don't want to kill you and get rid of you as the beginning of that domestication process. And I think, to me, that's the most interesting part of this entire thing. I think a lot of people think about domestication as if humans make rational decisions. But I think if you go back and you read the domestication of dogs or domestication of cats, essentially it might have been in reverse. They realized that we had a lot of rats. And so the cats started living closer and closer to us. And so they realized if they were acted nicer and looked cuter, they could get access to the rats. And so they sort of habituated us rather than the other way around is probably the way it worked. And that's the theory here is that it's just, we're not as smart as we think and we might be domesticating raccoons. And I thought that was interesting science. I don't know that I buy any of their phrenology, but there is something but it was less than a 3.5% reduction in snout length when you compare rural and urban raccoons. So urban raccoons apparently are getting cuter by their definition. I don't know if there was any value to anything I just said, but
I love this paper, and I don't know if my favorite podcast, apart from this podcast, of course, Justin, is a podcast called the Common Descent Podcast. I think I've probably sent you some of this stuff over the years, which is essentially two nerdy evolutionary biologists talking back and forth about papers. So, not too dissimilar to this podcast, but they have covered a few papers like this over the years in their news section. And I don't know if you know this, but if you go far enough back, before Darwin did, the Ascent of Man and the Common Descent and all that sort of stuff and wrote on Origin of the Species, he was a researcher. And do you know what his primary research topic was before he got big and famous?
I've known it many times. But
it was
I can't
barnacles. So he was like obsessed with documenting the evolution of barnacles, essentially, which is the most. But then his other big thing was he basically did domestication of or breeding pedigrees of dogs. And if you look at dogs, like essentially he tracked how not natural selection, but human breeding programs, sort of how dogs evolved over years. And I have 2 golden retrievers, and if you put them next to a wolf, you can definitely see this domestication syndrome is that they're big, dumb, floppy ears and round faces, with sort of doughy seal eyes. So, that's sort of the way it is. And so it's really interesting. I actually quite enjoyed reading through the technical side of this paper just to see how the science was done. And so they essentially captured all these camera images, and they actually come up with a pretty objective way of measuring. They got rid of thousands of images because they didn't have the exact side profile of the raccoon. So if you're out there, Canadians, taking photos of raccoons, just make sure you get a good profile for these people. Yeah,
ask them to pose,
and then they can show that their faces are getting shorter and cuter. So I thought it was quite useful. And they also they did lots of interesting corrections for like how far were you from an urban area, latitude, altitude, all sorts of things, because there's different evolutionary characteristics of raccoons. I've not really seen many raccoons in my life, Justin, but in your experience in your lifetimes, are raccoons around Toronto getting cuter and cuter, or not really?
So you will not find a Torontonian without very strong opinions about raccoons. I think if you're anyone in Australia, just Googles a raccoon right now and looks at the images. They are objectively cute. My kid has like 6 plush stuffed animals and absolutely loves them, but they are the most hated animal in this entire city. Like, we spend millions of dollars trying to protect our garbage because they are so smart that they'll get in. I don't know if it's animal cruelty. I shouldn't talk about it. I have basically sprinklers on motion detectors to try to get them out of my backyard. Otherwise, they crap all over my son's slide and tree house. Like, they are just the worst, but they are objectively incredibly cute. And I don't know anybody who doesn't sort of want to feed them by looking at them, except for they just get into everything and destroy. If you own a house, you do not want a raccoon. We have like multiple living in our parking garage at the hotel. In fact, recently they're probably living in the walls of the I keep saying hotel, of the hospital. Our C-section suite, our sterile OR. 3 raccoons fell right through the ceiling during the middle of a C-section. So that's how prevalent they are in Toronto. No, they're not well liked.
There you go. I think the Australian equivalent is the possum, which is like a marsupial that gets up into your living space and they make this horrible screeching noise when they're sort of trapped or.
I don't think they're cute, though. Are they cute? I don't know that anybody ever thinks
cute. Yeah. They don't have the big sort of black eyes like the raccoons do, but they are pretty cute. So I guess the bottom line is, Justin, how many years is it before they're cute enough that you're going to have a pet raccoon? That's the question.
Yeah, it ain't happening in my lifetime. That's for damn sure.
But I'm sure our ancient forebears who were sort of huddling by the fire in caves in sort of Europe didn't think they were going to be adopting wolves anytime soon, because wolves were big and scary. And, here we are with golden retrievers, a couple of thousand years later. So,
Yeah, I don't know. Maybe they'll be domesticated like cows. Maybe raccoon is delicious. That would be a good meal. I don't want them in my house, but if they're in a pen out back for a Sunday stew, maybe I'm on board. Sorry for all my vegan listeners. I think it turned horribly. If anyone's made it this far in the podcast, they aren't listening anymore. Good. So we're okay. It's all good.
If you do want a recipe for raccoon stew, just hit Justin on the Twitter, and he will send you his recipe for. I'm pretty sure that does happen in some parts of the States, but I'm not going to.
I think that's more Arkansas than Toronto, but I don't know. Try to alienate as many people as we possibly can. Oh
God! All right, I think we better stop it there before one of us gets shot. All right, mate. It's been great talking again. 2 months in a row. Hopefully we'll be back in the not too distant future to discuss more nerdy journals. And let us know what you think. As evidenced by this most recent piece of feedback, we are open to feedback, so please hit us on the email or through Twitter or wherever else if you want, through the blog site, and we will definitely try and do better in the future. All right, mate.
We will read it and we'll try. I'm not sure that we're any more organized than usual, so we'll have to get more feedback on the feedback, whether we actually work. But it was a pleasure talking to you. Hopefully we'll talk again soon.